Thank you, Mira, for the introduction, and thank you for the invitation to present our work here today. It's an opportunity for us to share some of our developing ideas in a project which focuses on the oral manifestations of scleroderma, which is a rare chronic disease of the immune system, blood vessels, and connective tissue. There are 2.5 million people worldwide who have scleroderma, including around 19,000 in the UK and about 6,000 in Australia. It's characterized by fibrosis of the skin, organs, and connective tissues. The fibrosis is caused by the production of excess collagen, which leads to a characteristic thickening and hardening of the skin and internal organs. Any part of the body can be affected, and the umbrella diagnosis can be experienced very differently, depending not least on the type of scleroderma that a person has. There are two principal types, localized and systemic, and we are concerned with systemic scleroderma here, which itself is split into two types, limited and diffuse. And you can see the range of symptoms on the slide. We hunted high and low for a symptom slide, which included oral symptoms, and we didn't find one. Most had nothing above the neck, so this was the only one that at very least referenced the face. So whilst limited scleroderma will gradually worsen over time, it tends to be less severe and more controllable than diffuse scleroderma, which can cause serious and rapidly progressing problems with the heart and lungs in particular. Given that cumulative survival from diagnosis has been estimated at 80% at 5 years and 60% at 10 years, it's perhaps not surprising that at the point of diagnosis, clinicians tend to focus on the significant threats that the disease poses to the internal organs. But there are other significant aspects of the condition which tend to be very poorly understood or addressed and have a significant negative impact on people's quality of life. One of these is the oral and dental manifestations of the condition, and we became aware of this issue in the context of broader research on autoimmune conditions, but also through a study which Liz Price, one of the study's co-investigators, had been undertaking for a project which focused on people's experiences of radical dental reconstruction. Now, the oral symptoms of scleroderma can include microstomia, so that's a limited mouth opening, dry mouth, muscular atrophy, thin lips, xerostomia, oral fibrosis, ulcers, and salivary gland disorders. These physical issues are unsurprisingly accompanied by profound assaults on a person's sense of self and identity, given that the oral cavity plays a very important role in a person's sense of well-being. The concerns that people have, however, tend not to be shared or recognized or validated by the clinicians involved in their care. I think I might echo some of Alex's findings from her paper, and that applies to both dentists and rheumatologists. This lack of awareness to oral health may reflect, as I've said, that it can be perceived as secondary importance to its threat to internal organs, and this contributes to a lack of awareness of the impact of dental problems and dental treatment options available. For dental professionals as well, this creates what we've termed a critical awareness and referral gap between rheumatology and dentistry. And this was absolutely the case for our respondents who said, if I can bring that up, yes, there we are. My local rheumatologist didn't even seem aware of it. I don't think doctors always understand the psychological problems which this causes. I never get asked. Dentists had not heard of scleroderma or the effects. They don't understand that you can't open your mouth. I told them they had no idea what it was. I had to spell it for them. That was a common refrain. So we were interested to understand why issues which are of such concern to patients are not adequately addressed by clinicians. There was a really inverse experience. And second, we wanted to look at mechanisms for raising more awareness of problems which patients experience, both with rheumatologists and dentists, with a view to ultimately shaping guidelines for care and referral. So it was a grant call from Scleroderma and Raynaud's UK, a UK-based charity, which focused on improving quality of life in particular, that offered us the opportunity to do this. And our funded project has 4 key objectives. We wanted to explore the experiences of patients. We wanted to document rheumatologists' awareness of scleroderma, related dental problems, and the ways their strategies, current strategies for referral. Similarly, in relation to dental professionals, and also we wanted to work with patients and practitioners to co-produce and optimize referral pathways and clinical guidance to improve preventive dental care in scleroderma. We used a concurrent mixed method study design, and this comprised 4 elements: systematic scoping review of the literature, 3 online questionnaires with patients, rheumatologists, and primary care dental professionals, in-depth qualitative interviews with people living with scleroderma, and we are currently at stage 4 at the moment, which is the co-production element. We're currently holding co-production workshops over the course of the next month with patient participants to share feedback from the research and collaboratively develop information tools and referral mechanisms. We recruited many of our patient participants through SR UK, as well as an existing large-scale study, the STRIKE study. It's a clinical trial of scleroderma, and that's based at Leeds University. And our clinicians were all recruited through UK professional networks. In this presentation today, we're focusing predominantly on the patient data that we've found. Our data analysis is ongoing, and it's being undertaken using a combination of thematic and narrative analysis methods. The patient respondent demographics very much reflected a standard autoimmune scleroderma profile, so overwhelmingly female, middle-aged, and in the context of this project, white British. All 4 countries in the UK were well represented in this group of respondents, and as you can see, many of which had been living with scleroderma for a significant number of years. So I want to start today by looking at what were some of the patient experiences, and this is what some of our patients were saying to us. I can only use a small teaspoon or baby fork to place food on my mouth. I can only put tiny pieces in. The food has to be dissolvable because I cannot position it with my tongue and I choke. Food gets stuck at the side or back of my mouth and I cannot swallow it. I have to rinse it out. I mostly live on Ultraplen shakes. My swallowing muscles into my throat are weak and the food goes into my nose and sometimes my lungs. Severe microstomia causes my front teeth to only open 15 millimeters apart. My dentist has difficulty seeing into my mouth. My tongue is fixed and I don't know if there's still food in my mouth. Broken teeth, shrinking gums, removal of teeth were all commonplace and mentioned pretty much by everybody that we've spoken to. Why, though, are these issues relevant in the context of our theme this morning, which is on stigma? And I'm going to take a brief theoretical wander to look at this. If you all think for a moment about your own mouth and teeth, they're probably things that you actually don't think about, other than for the few minutes you spend every day poking, brushing, and flossing them. If you have a problem with your mouth and teeth, though, it's very likely that parts of your body that ordinarily sit quite comfortably in the bodily background are thrust into the center stage. And if you have toothache, for example, it's probably not possible to really think about anything else. So in this context, The site of concern and distress moves to center stage in a person's life. We have found that the work of US philosopher Drew Leader quite useful in helping us to understand this personal and social repositioning of the mouth in this instance. Leader argues that our bodies ordinarily spend a significant amount of time in what he calls the corporeal or bodily background in the way I've described. So we tend to be completely unaware of significant parts of the body when they're not in use. Leader refers to this as corporeal absence, and it can include any part of the body, including our internal organs, which continue to undertake the necessary processes for life beyond the boundaries of awareness. So for the most part, the teeth and mouth exist in this same corporeal background and remain taken for granted, and a largely unproblematic aspect of everyday life. Illness, disfigurement, psychological distress, and social pressures, though, can shift the body into the foreground, where it can assert itself in dysfunctional ways. And when this happens, the body loses its previously taken for granted background status and shifts to center stage, getting in the way of everyday life. And Leader refers to this dysfunctional appearance as bodily disappearance, as we've spelt it here. This concept is exemplified by one of our respondents who says, it's only when you realize like brushing your teeth is really difficult because it's just so painful that you start to think about it more. We are particularly interested in the wider concept of disappearance because in scleroderma there are multiple ways in which this can take place. Firstly, the mouth disappears in Leader's context, i.e. it dysfunctionally appears. But it also literally disappears due to the microstomia associated with scleroderma. And finally, the mouth, according to the respondents in our study, is also actively removed or disappeared from clinical conversations about the impact of scleroderma. These varied metaphorical and very real absences are something that we want to explore further as we deepen our analysis in moving to the conclusions of our study. There is, we think, also a profound experience of stigma embedded in these various articulations of disappearance, not least the very real public humiliation and private shame associated with poor or failing dentition, particularly in countries where access to contemporary dental interventions should be completely unproblematic. This is a stigma that is keenly felt by people living with scleroderma. A critical source of shame and stigma for respondents in our study was the sense that clinicians and society more broadly blamed them for their dental problems. So again, this was very much a problem which was exacerbated by dentists' lack of awareness of the condition and rheumatologists' lack of awareness, as the following quotes suggest. And we refer to this as iatrogenic stigma. I feel like the dentist judges me, he blames me even though I clean my teeth. You just automatically think it's your fault. When you first have these problems with your teeth, I think because it's drilled into you as a child and as an adult, you must clean your teeth and floss, and the first thought is, oh my goodness, I am doing this all wrong. I worry that people will notice. Nearly everybody else I know has lovely teeth. I don't know anybody with as horrifying teeth as mine. I probably am worried about what they're thinking, what they're assuming I do with my teeth. You know, I don't look after them or whatever. So people had a profound sense of internalized shame, and stigma, and social expectations around dental health and dental care led to shame, embarrassment, self-consciousness, humiliation, all combining to create a significant sense of shame. One person said to us, I don't smile. I'm so ashamed of the way my teeth look. I avoid eating out with family and friends. It takes ages to clean my teeth and I feel awkward. Sometimes if I'm cold, I can't form words properly and I think I sound stupid, so I don't talk. I hate how I look around my mouth, so I don't wear makeup anymore. Some days I feel very down about things. This sense of shame had a significant impact on people's sense of self, as the following slide suggests. I feel embarrassed that I choke. I feel upset that I cannot sit with my family and friends to eat and drink. I'm frightened that I will not survive scleroderma because of my mouth. I hate looking in the mirror and seeing how disfigured my mouth is. I dribble and sometimes spit when I'm conscious of how I look when I smile and eat. I'm consistently reminded every day, due to problems, that I have this horrible condition, and that's depressing in itself. I'm extremely self-conscious of my dry lips and broken teeth. I shy away from going out and having to talk to people. I've lost so much confidence that wearing a face mask is actually a relief. However, as I noted at the start of this presentation, despite the profound impact of these oral and dental problems on people's lives, these issues are rarely addressed by the clinicians in their care. Now, we haven't pulled the data from our clinicians together in the same way as we have with the patients, but this slide gives you some key headlines in this context from the clinician surveys. As you can see, 86% of patient respondents were not informed about the potential oral problems at diagnosis, so they had no idea that this was coming their way. Only one rheumatologist referred to oral and dental problems in our online survey, and dentists generally expressed very low confidence or low confidence in managing the oral problems associated with the condition. So whilst the project is obviously ongoing, we have started to identify some of the critical issues that we want to take forward into our final stage. In terms of patients' clinical experiences, it's very clear that patients and clinicians do not always shape or share the same priorities. Clinical encounters are shaped by clinicians' principal concerns that don't always offer a space for patients to articulate what aspects of the condition most profoundly impact upon them. And we hope that one of the outcomes of this study will be to better underline this for rheumatologists. And we are exploring ways of doing this with our key stakeholders. The British Rheumatology Guidelines for the Management of Systemic Sclerosis are currently under review. One of our co-applicants is part of this working group, fortuitously in this case. Numerous patients in our study told us that they felt a responsibility and wanted to educate and inform dentists about scleroderma, and dentists told us that they wanted this information. So we're currently looking at ways to enable people to do this, but which creates the less possible stress for the patients themselves. And we're currently co-designing information tools with patients to do this. From a theoretical perspective, we're interested in exploring the multiple ways in which scleroderma and the mouth can both literally and metaphorically disappear. And we're keen to understand the meanings of this disappearance for both clinicians and patients. Our overriding concern, however, is to fulfill the original brief we were given by SRUK, and that is to improve the quality of life of people with scleroderma. And our hope is that this work will go some way towards doing that. Thank you.
Have any questions for Liz? Jonathan.
Liz, that was extraordinary. Thank you so much. I was thinking in relation to some of the work on my berry around biological disruption, in terms of the styles and strategies that people accommodate to live with the reframing that's often associated with illnesses like this. And certainly from some of his work, some of them are quite enabling, putting people in a position where they can proceed, albeit with a very changed environment in which they're living, associated with their illness. But looking at some of the narratives from your study, there appear to be coping styles or different mechanisms in place, but they accommodate a very negative tone in terms of shying away, not doing things, not being seen. And I just wanted to get your views on that in terms of whether that is utterly reflective of this individual population group, or whether there were some people who gravitated to a much more optimistic space.
I think, John, it's a good question, Jonathan, and I think it probably depended on a number of things. People struggled to access dental treatment. So I think if you had access to dental care, dental treatment, if you had the financial resource to do that, that was an important aspect. I think if you knew from earlier on in your diagnosis that this was a potential problem, then I think preventive engagement was much more positive and much more of a possibility. But I have to say, it was I don't know, I mean, two of my co-authors are here today, Liz and Tyler, but I don't know in terms of your reading of the data that we really found a great deal of positivity in terms of how to manage it.
We might just take one question, I think, from the back there was first, and then we might have to close, I think, and move on, I think.
Hello, thank you very much. That was really interesting, and I have to say at medical school we never covered that, so that was very useful. I know there's lots of problems accessing NHS dentistry at the moment. I think you mentioned that you'd looked at the 4 different parts of the UK. Were there any particular differences in access there? And was there any links to being able to kind of be prioritised for access because they had scleroderma?
I don't know. Tyler, if you know if there were any specific differences in terms of access to care across the 4 countries. I don't think that there were. I don't think that we did find that. You would think that this would be a priority, for example, for specialist dental care. The answer to that is no, it isn't. And that's one of the things that we're trying to make happen as a result of this. There's this terrible gap whereby dentists, rheumatologists, special care dentistry, nothing is connected. So nobody is able to access precisely the referrals that they need.
And I think, Liz, there's another whole group emerging with exposure to silica. So that's been a big occupational discussion in Australia, and I'm sure they will be predominantly men and have an occupationally acquired scleroderma, which will be another group of patients that will need to be thought about as well in this question.